Good afternoon, everyone, and thank you for joining us today for this important Health for Life series. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and we thank you all for taking time out of your day to participate in a very informative, I'm sure powerful presentation today, just knowing my experience with our guest speaker for today. So the session today is the beginning of a series that we will be hosting. It's a 5-part series on Let's Dismantle Diabetes. Today's session is entitled Diabetes in the Black Community, Why Us? So I'm excited to hear what Courtney has to say today in response to answering that question and giving us a little more insight and knowledge around why our community is impacted more so than many others when it comes to diabetes. So we're happy to have Dr. Courtney Walker, who is the Health Equity Outcomes Director for the Health Equity Division at Novo Nordisk. And so why are we here today? Yeah, we're going to talk about diabetes, but more importantly, I think what we need to know is that when we look at what's happening in California for diabetes in the Black community, we know that on average for the state, it's about 17.5% when it comes to the Black population, comparatively speaking to the US, about 15.5%. So we're a bit above the overall average for the country when it comes to diabetes and the Black community here in California. And I think the most startling thing for me is when you look at the number of diabetes-related deaths per 100,000 people. If you look at for California specifically, when you compare the Black community and Black population to the white population is 18.5 per 100,000 diabetes-related deaths compared to 51.8. That's 51.8 for the Black community here in California when it comes to the number of per 100,000 deaths and diabetes-related deaths here in California. So that is one of the highest in the country and very astounding for me, especially for a place like California where, we're talking about healthy living and healthy lifestyles here. So definitely an issue that we need to address for the Black community here. And Courtney today will give us, again, more insight into why this is happening, more so to the Black community than any other community or population of those who are dealing with diabetes. And so just for today, we want to have an interactive session. We know it's set up as a webinar, but for your questions, please drop those in the Q&A box. But if you want to give a shout out to someone that you recognize who's here today in the chat box or want to make comments throughout the session, you can place those in the chat box. For the most of the session, everyone will remain muted, but you can ask your questions again in the Q&A box. So before I introduce Courtney specifically, I wanted to just give a little bit of information about CBHN for those of you who this may be your first time participating in one of our events, but we, happy to say, are celebrating our 40th anniversary this year. CBHN was founded in 1978, but became officially a 501c3 in 1983. So hopefully some of you who are in California, more specifically in Sacramento on May 4th, will join us in the celebration and those festivities. But generally speaking, our vision is to create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we do that every day through carrying out our mission to ensure that all Black Californians, regardless of how well educated they are, how much money they make, where they live, who they love, how they identify themselves, or even their housing situation, or even where they're from, has access to high quality, equitable primary as well as behavioral health care, and definitely avoid unnecessarily succumbing to a disease like type 2 diabetes. And so I want to take a moment to introduce our guest speaker for today. We have a great relationship with Courtney and Novo Nordisk for about 2 years now. But Courtney Walker is as I mentioned, the Health Outcomes Director for the Health Equity Division at Novo Nordisk. He has a ton of experience in the health equity field. We've done a lot of things together in this space. So I'd like to say it's because of me that Courtney got his promotion, but that's not necessarily true. You know, he's worthy of it all on his own. And so in his role, he spends a lot of time really focusing on more of a broad strategy for the organization around health equity and what they can do to advance health equity on a nationwide basis. But he is super busy. He engages with other organizations like British Petroleum, Southwest Airlines, AT&T, and a host of others when it comes to diabetes and obesity for their employees. And he's very passionate about a lot of things that he does, especially in the health equity space, and especially as it relates to diabetes and obesity and the interconnection between the two. He is a proud graduate of Texas Southern University, College of Pharmacy and Health Sciences in Houston, Texas. And when he completed his doctorate of pharmacy, Dr. Walker completed a managed care pharmacy practice residency with Humana in Kentucky, and also the University of Kentucky's College of Pharmacy in Lexington, Kentucky. He's got a lot of experience in pharma. He worked for Eli Lilly at one point, Johnson & Johnson, and anything else about his career and experience that he wants to share, I'll let him do that. But without further ado, I'll turn it over to Dr. Walker to give us information about why us when it comes to diabetes in the Black community today.
Thank you so much, Rhonda, for that wonderful introduction. And thank you so much for the opportunity to share with you guys on today. I'm going to open my slides at this time. It takes a little while. Can you see now, Rhonda, my slides? Are they available?
Yes, perfect. Thank you.
Excellent. So again, thank you guys so much for this opportunity to share. And I'm looking forward to this conversation, Dismantling Diabetes, the why, session 1. And really, this is not going to be a hugely clinical presentation. It's really going to be conversational, where we really address diabetes at the root and why it's such a significant problem in the African-American community. And to do that, we have to understand what is going on in the African-American community. I'm going to share a quote from a book which came out last year, How COVID Crashed the System, A Guide to Fixing American Healthcare by Dr. David Nash out of Temple University in Philadelphia. He quotes the Philadelphia Negro, book written by W.E.B. Du Bois. In 1896, W.E.B. Du Bois was given the task of going into what he considered the slums of Philadelphia to figure out why the African Americans' health seemed to be worse than other members of society. And his contention was that the shorter lifespan of the African American had not to do with innate inferiority, as what had been taught by the majority population and what had been sort of put out there, but it was due to 3 things. It was the places they lived, the food they had access to, and their education, which are the social determinants of health. And we're actually going to talk a little bit about that in detail today, because that is a part of the problem when you take in consideration diabetes, and how we dismantle it is by understanding the issue. And the issue is that from 1994 up until 2015, we have seen a considerable increase in diabetes. And if we see that the darker red that the United States has become indicates the greater prevalence of diabetes and obesity. Obesity will be intermingled in our conversation today, because what we know about obesity is the bigger we are, the more we are susceptible to what is called insulin resistance. Insulin resistance is a symptom or a product of type 2 diabetes, which consists of 2 problems. Typically, insulin deficiency, which is a problem of your pancreas being able to produce insulin to help sugar get inside the cells so our bodies can use it. And then the other problem is insulin resistance, which correlates sometimes to increased size, increased weight, and the ability of our muscles to use the actual sugar that we're taking in. And when we're taking so much in and not able to get it into the cells to be used, it sits in the bloodstream and it causes the problems that Big Mama called sugar. She didn't call it diabetes, she called it sugar. And so because of that, the problem has been perpetuated within our community. So when you see nationally a problem, the red indicates the problem has gotten worse. It tends to affect the 13 to 14% of the African American population much worse because of the vulnerability of the African American population. When you jump on top of that and you look at hospitalizations for diabetes related complications in the US by age, you take in consideration events in diabetes from 18 to 44 years old to 45 to 64 and 65 and up, you see acute myocardial infarction or heart attacks, strokes, amputations, high blood pressure, and kidney disease are all byproducts that are considerable problems that correlated with those years. So as we went from 1995 to 2015, in addition to the nation getting darker or an increased prevalence of obesity and diabetes, we also saw an increase in these disease events, which are hugely impactful to the African American community, to our families, because it really connotes health. And also, when you think about the $1.72 trillion associated with disease as well, we know that there's a considerable problem. When you look at diabetes and obesity in the United States, also you look at 49.6% rate of obesity in the United States, specifically in the African American community. When you take in consideration the average right now is probably about 45%. African Americans have a larger percentage of individuals struggling with obesity. Black Americans are 50% more likely to have type 2 diabetes. And then we also understand that the risk of death in diabetes actually is high as well. Black Americans are 2.5 times more likely to die from the disease than white Americans. We know specifically from an obesity standpoint, remember again, this is significant because of the impact of insulin resistance. Is 1.3 times more likely for Black Americans to be obese, and then also 4 out of 5 Black or Hispanic American women have obesity or struggle with being overweight. And a lot of those factors have to do with access to healthy food, places to exercise, access to medical care, affordable insurance, and also employment in lower wage jobs have a huge impact. And we're going to talk about that impact as we delve deeper into this issue. So what is the real issue? The real issue has to do with inequalities in health. I think about this quote from Alexander Den Heyer and also repeated by Dr. Kamar Phyllis Jones, who's at Emory University, who states that when a flower doesn't bloom, you fix the environment in which it grows, not the flower. And when you think about a flower, what are the factors that affect the health of the flower? You have the soil, okay? The soil has to be right. Sunlight has to be right. Carbon dioxide, oxygen exchange has to be right. Water has to be right. Sunlight, all of these things working together to ensure that the flower has an environment for which it can flourish and it can grow healthy and strong and vibrant and beautiful and aromatic as well. And the same is true for a person. When a person doesn't have the environment that provides all of those factors similar to a flower, then we wonder why the health situations are what they are. Sir Michael Marmot out of London says inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. So we understand power, money, resources have a huge influence. And this pours over into a recent quote by Risa Lavizzo-Mari out of the Robert Wood Foundation, who says that they know now that a child's life expectancy is predicted more by zip code than genetic code. Where you live is an indicator, just as W.E.B. Du Bois recognized in Philadelphia, that the places that African Americans in the city had to live had a huge influence on the overall health. The same is true for African Americans in the United States in this time, in the states, in the places. I live in Dallas, Texas. There are zip codes where individuals live, which are predominantly African American, where they're 2-hour bus ride from the nearest grocery store. When you take that in consideration to other communities, I'm very sure here in California. My father lives in Culver City, California. And so certainly I'm very familiar. There are areas where the access to quality foods, can be a struggle, for some individuals. And so zip code has a huge connection to health and life expectancy. So we have to think about that more. And so why is that significant? Because when you dig down into the socio-ecological framework of an individual is the sum total of all these different factors. Number one, interpersonal factors, right? Their family, their culture, their values, right? That works to help to create the person. Then organizational, the schools, the community organizations, faith-based organizations, the churches, the healthcare organizations they have access to, the community, parks and recreation, neighborhoods. Do they have an ability to go walking, to go exercising, to get outside, to be active, to go explore, to go walk? And then ultimately public policy. Are there laws and government regulations, media that really feeds into the individual being as healthy as possible? And we know that all of these factors, when it comes to African Americans, have been a challenge over the years. I was at a presentation in Wisconsin, and one of the things that we were talking about was the health of the minority population in the area. And, one of the areas where they shared with me was a struggle was having to do with decreased investment in recreational parks and places for kids to go play and elderly people to go walk. They felt that those things had been lacking and neglected in the cities, and that had a direct impact on health. And what we know is diabetes certainly is an offshoot of lack of physical activity, is an offshoot of those types of things, which certainly can, and then also lack of quality foods that certainly play a role in the development of diseases like diabetes. And then in the African American population, we have to take into consideration our very unique history in this country. When you consider slavery from 1619 to 1865 and structures of racism and white supremacy and post-emancipation structures of racism, directly related to white privilege, and then Jim Crow laws, segregation, redlining, targeting African Americans, all of these things, and then the racial bias in the justice system, and then concentrated poverty and social determinants of health issues, leading to poor access to health care, poor housing conditions and physical environment, poorly funded schools, poor access to capital. It is no wonder it is directly related to now increased cardiovascular disease, stroke risk, toxic stress, leading to diseases like type 2 diabetes and an increased burden of health outcomes. So when you talk about the African American and the plight of the African American, we have to take in consideration the very unique history of the African American has had in this country and understand what we can do to bring about change and moving forward. And understanding systemic racism and definition has to do directly with understanding health inequities in the United States, understanding minority populations having lower high school graduation rates with individuals and household incomes below the federal poverty level, uneven access to quality schools, good paying jobs, great neighborhoods, health insurance, quality medical care, racial inequities in the fatal US police shootings, all of these things having a direct impact on the African American community, and thus these numbers that we see. And then understanding health equity. One of my jobs is to understand health equity. The difference between equity and equality is everybody gets to go to the game, but everybody doesn't have the same access to view the game. What equity is, everybody's at the game, and we take measures to ensure that everybody has an equal ability to see the field. So the person who's tiptoeing to see the field has something put under them. The person who has the wheelchair has a block put under them, so that everybody has an equal ability to be able to see the field the way they should. And then when you define health equity, it is the ability to remove barriers to ensure that everybody can reach their full health potential. Doesn't mean that everybody will take advantage, but really the barriers being removed. And so this is what this conversation is really about. And And then what is the approach? The approach is to evaluate the social determinants of health that are applicable to ensure that that goal can be achieved. And that's typically out of what W.E.B. Du Bois was talking about, where people grow, they live, they work, their age. And he understood that these social determinants of health, education, transportation, housing, social support, digital health, access to digital health literacy, access to care, all of these social determinants of health factors are extremely important in determining what? At the bottom, health outcomes, morbidity, mortality, quality of life. And this is what we're talking about. And this is what we're really trying to say, like, we can no longer be health equity tourists where I make it akin to a person driving and rubbernecking and seeing a car accident and saying, oh, that's so bad, and just speeding off to go and handle their day. What we're trying to do now is be a part of fixing the solution, being a part of actually staying and researching and figuring out what can we do differently? How can we have partnerships with organizations that can help with issues of transportation, issues of rurality, issues of improving education, improving income, improving access to care. Those are the things that we're trying to do to make a lasting difference. And that's what's important, because what we know is, for example, from an educational standpoint, from when you look at this example, better education correlates to better health. Lower education correlates with poorer health. And all of this is directly impacts what we see from a diabetes perspective. And to go back to the example of the flower initially, then let's correlate that and make it look like to the person. When a person when you examine the effects of social determinants of health on people, we talked about if a flower doesn't have water and doesn't have sunlight and doesn't have good soil, you can't expect it to be healthy. We have to evaluate from a person perspective the impact of some of these socioeconomic factors, these social determinants of health, and how it affects individuals. Studies show that clinical care only accounts for 20% of a person's health. Access to care, 20% direct patient care. But look at the rest of the influence. 40% is going to be the socioeconomic factors, education, employment, family social support, income, community safety. 30% the health factors, tobacco use, diet and exercise. That's in the 30% category. Alcohol use, sexual activity. And then 10% the physical environment, the ability to be able to have a place, a secure place to live. All of these factors work to determine the health and well-being of the individual. And that's something that we're having to think about more to make a significant difference. And also to think about our environments and the change of our environments. Think about the obesity rate and the impact of how we eat in this country. In the 1950s, the average soda was 7 ounces. 7 ounces. The average soda size now is over 42 ounces. When I go to a Whataburger or an In-N-Out Burger, shout out to California. Thank y'all for In-N-Out. We actually have them here now. When I go there, they always want to supersize the drink, give you 40 something ounces with a regular meal. This is a 6-time increase in sweet sugary drinks that have high fructose corn syrup in them that has a tremendously high glycemic index and has a tremendous effect on overall health and moving us towards insulin resistance, moving us towards type 2 diabetes. 3.9 ounce hamburgers in the 50s. The average size of a hamburger now is 12 ounces. That's almost 4 times the size of our burger. French fries, 2.4 ounces. The average size now is 6.7 ounces. So when you think about the effect of our diet on our size, then the effect on that on overall health, leading to some of these problems, is significant. Other factors, sleep deprivation. We're not getting enough sleep. We're stressed out. And then think about what I mentioned earlier, specifically in the African-American community, the toxic stress, right? Physical inactivity, which they say will be considered as dangerous as secondhand smoke in this day and time. That physical inactivity is going to have that type of effect. Epigenetic modifications in our foods, where our foods are different, One of the most impactful books out there for me was Wheat Belly, where he talks about the wheat molecule being changed in the late 80s. And from the time that the wheat molecule has been changed from a chromosome standpoint, we've seen a significant increase in allergies, diseases, of gastrointestinal diseases, because the wheat molecule is not what it was when we were growing up in the 70s, early 80s, because they made modifications to it. And how do these genetic modifications affect our health, and how can we do things to bring about change? So let's get into the disease and talk about the disease a little bit. So when we think about diabetes, there's going to be two classifications that we're going to focus on. Type 1 diabetes, which is the destruction of the beta cell in the pancreas, and often leads to absolute insulin deficiency, an inability of your body to produce insulin, which job is to help sugar or glucose get inside the cell so it can be used to power our bodies, right? Or the cells can function. The skeletal muscle cells can do their job, or all the cells in the body can do what their jobs are. Type 2 diabetes is different. It's due to a progressive defect in insulin secretion in the background of insulin resistance. It's a little bit different. It is more so about a defect. And again, whether it's due to size, whether it's due to family history, whether it's due to other factors where our body doesn't respond to insulin the way that it should, and therefore we have excess sugar in our bloodstreams over time. Gestational diabetes is uniquely related to those who experience this during pregnancy, women who experience it during pregnancy. However, when they are diagnosed with gestational diabetes, they have a higher percentage likelihood to have type 2 diabetes later on in their lives. So that's certainly something that we have to take in consideration as well. So when we think about risk factors, I want to focus on the terms modifiable and non-modifiable risk factors, because I think that's extremely significant. When we think about, number one, non-modifiable, we can do nothing about them. We can't do anything about them. So we can't do anything about race. We can do nothing about family history. We can do nothing, or the first degree relative with diabetes. We can do nothing about age. We can't do really anything about gestational diabetes per se. Those are the non-modifiable risk factors. But the modifiable risk factors, things that we can change: weight, physical activity, blood pressure, cholesterol, smoking, diet, alcohol, stress, sleep. All of those factors are ones that we can do something about. And that's a part of the conversation within the African American community, where we have to take personal responsibility to say, how can we encourage our community to be better in these modifiable risk factors? And so that's a significant part of the conversation. And certainly, Rhonda, when we get to the discussion part, I'd love to hear some of your thoughts on that as well as we talk through that. But modifiable risk factors are going to have to be a significant part. This will support our physicians in the relationships with patients, and help us to move towards better health. And that's going to be diet, making better choices and decisions, and making wiser decisions where diet is concerned, because those are the factors that are really affecting our community in a way that we have to really stand up and do something about. Rhonda, do you have any comments on that, just the modifiable risk factors, before I continue?
I do. I've been taking notes as you've been talking. But on the modifiable risk factors, one of the reasons why we are doing this whole Health for Life initiative and different series that are part of that is to really improve or help improve the health literacy of folks in our community. But also we view health literacy being on both sides of the patient-provider relationship. So we'll do our part to create a more empowered community, to educate them on how they can take more of a proactive stance on their health and well-being. But also we want to make sure that the providers who are caring for them do that in the right way and in an equitable way. But we'll eventually get to that. But to answer your question, I think it's important for us to think about this right in the context of social determinants of health, because we know, right? So if someone who's living in a food desert, but we know when it relates to type 2 diabetes, nutrition is a important part of one of the key parts of prevention and management. So how do we really address that issue when you live in a place where there's a fast food restaurant on every corner, and that supersizes everything, right? To your point earlier. Or, there's no grocery store like a Whole Foods or even a Trader Joe's where you can get access to and purchase, quality, healthy, fresh produce. So those are the kinds of challenges I think that some of our, depending on where they live, community faces. So I would throw it back to you and say, what do we do in those situations when we talk about that aspect of modifying and making choices, right, to help prevent type 2 diabetes or more effectively manage that?
I think it's a great question because it goes back to the comment of zip code connecting to life expectancy, right? So when you have areas that lack resources, unfortunately, we've had to see that drastic measures have to take place. And I know in California, for example, you have a gentleman who started a community garden. And he was known all over the country because he started a community garden and provides fruits and vegetables to the community.
Is that the
We
gangster
actually
gardener?
the
The
gangster
gangster
gardener,
gardener.
yeah, absolutely, yeah, phenomenal. But that's the key. It's about understanding that the key is going to be how we eat, what we take in, being responsible for our diets. Here in Dallas, the same concept was actually started by a Californian that came here to Texas and started what's called Bonton Farms. He went to an area in the inner city and started a inner city farm in the area that had the highest percentage of cancer, kidney disease, heart disease, diabetes, and started Bonton Farms. And actually, they've seen improved health outcomes because they have provided for the community fresh fruits and vegetables. So I would say, number one, I think a part of what we're going to have to do is empower our community. Number one, to recognize what's going on, to recognize that, hey, if you're relegating yourself to eating just fast foods, greasy fast foods from that fast food doesn't mean better food. Quality has to be taken in consideration. And we got to get away from this mindset in order to eat healthy is expensive. And in some instances, some of the stores, the prices might be different, but we've got to fight for solutions. We've got to look at, food banks or looking at organizations that provide fruits and vegetables for inner city communities in a way where there's access to this, to fresh fruits and vegetables, and being encouraged to cook at home, to prepare meals at home, encouraging our community that way as well. I think we have to continue to do that because that's the only way things are going to continue to turn around, because the way we are right now, you're relegated to cheap meals, fast food meals, high sugary, high glycemic index meals. When I was in Europe and had ice cream, and I remember I called my wife because she studied abroad, and I was like, hey, the ice cream's not sweet. And she said, it's because they don't use high fructose corn syrup. It's outlawed there, but yet we have it here. And it's just so sweet. And the glycemic index is so high, and it really facilitates an overburden of sugar that we really don't need. And that's a part of the problem as well. So I think we
So,
have to fight for solutions that matter.
yeah, great. I'm glad you raised that point because I was going to ask you about that. I know we talked about that in one of our prep conversations. And so, because would you say the fructose sugar is outlawed in Europe, so do we see then a difference in the rate of obesity and diabetes in those countries where that is prohibited as a food additive?
Oh, absolutely. Oh my Lord. Yes, we're bigger than everybody. Yeah, we're substantially bigger. I don't have all the numbers, but I know for a fact, we struggle with obesity in a very, unique way. Even the sumo wrestlers, most of the weight that, they consume a lot of omega-3 fatty acids. It's not so much the bad health that people equate, because they're athletes, and again, they consume a lot of fish, so a lot of that weight is not as bad as you think it is, different type of fat. But yeah, we struggle in a way differently. I mean, our portions are larger, our sugars more intense. So absolutely, yeah, we have issues. And then, for example, my company's in Denmark. Novo Nordisk is in Denmark. When I go over there, the whole community rides bikes. I mean, you'll be in a cab and there's 80 to 90-year-old women riding bikes right beside you. in the community. Like I mean, it's hundreds of bikes. Everybody is physically active. And one of the things at our company that I learned is when they have their screening day, where you do screens for diseases. So let's say, for example, your company has a diabetes screening day. Well, over there, it's a fitness test day. They don't see it as disease. They see it as, am I more fit than my other colleagues and coworkers? Another thing, when I was over there, when you get off the elevator, every floor has a basket full of fruits, apples, oranges, bananas, pears.
Right.
So everybody grabs a piece of fruit. So
Yeah.
there's no vending
No vending
machine.
machines as opposed to cookies and potato chips and
Right.
donuts and all
No,
that stuff. Yeah.
it's fresh fruit everywhere. And I was blown away. So it's every floor. So I grabbed the apple. I was like, wow, that was what the snacks were. And so again, they don't struggle with some of these problems because it's a society that has said, hey, we're going to be responsible in this way. And I think that there's something we can learn from that, but we have to do the work within our community to bring about that change.
Well, that kind of reminds me, like the rest of the country here in California, there are no smoking. That's no smoking in offices anymore, right? So wondering if there's any way to engage in policy initiatives that might mirror what you just talked about in terms of, like banning unhealthy foods from office buildings and things like that, as a potential solution or one part of a solution for that.
One thing I do know to that example, one of the oil companies here in Texas did an experiment where they removed all of the kind of unhealthy foods from the oil derricks where the men went out into the water and went to do the oil derricks, and they replaced them with healthy options and healthier food, and they saw a tremendous increase improvement in health, across the board when they did that. So you have to do, the interventions have to bring about change to really encourage healthier eating, healthier, opportunities for those individuals.
Right.
So
And access is key, right?
better access, absolutely, number one. And that's how we dismantle diabetes. We're going to dismantle when we take an honest look to say, hey, what can we do to bring about change? How can we help with screenings? How can we do with body mass index awareness? Like, where's my weight? Understanding physical activity, the problem of physical inactivity, and that's why I really say, when you look at these diabetes risk factors, this was an area where I wanted to stop. Acanthos nigricans, right? Looking at the necks of our kids go to a school where they have nurses look at their necks, and if they see the darkness in the neck, they immediately kind of will send us a thing saying, hey, what's the risk for acanthos nigricans in your family?
Can you translate that into like layman terms so that we
Okay,
can
I'm sorry.
understand what you're
So
saying?
acanthos nigricans is a darkening of your skin. It's in your neck, your back, and in the African American community, it's noted as a precursor to diabetes. Okay, and so it's an indicator. You can also see little mole-like lesions on the neck and on the back. And so it's indicative of those who have maybe moving towards pre-diabetes, and that's where I was going to go next. When we talk about pre-diabetes, that is the ramp way heading to diabetes, and so they are looking earlier in young people to get an idea to say, hey, could some of these markers be here, which are a sign of insulin resistance, and insulin resistance again leading as a precursor to full-blown diabetes.
Great. So I have a question. Oh, go ahead. I have
Yes, no, go ahead. No, go ahead.
I know you have other stuff that you want to cover, but so I'll take a pause on my questions and then I'll let you finish, and then we'll address some of the questions that are in the chat and get back to.
Oh, okay. We got some questions in the chat already. Okay,
Yes.
great. All right. I'll go ahead and try to sum some things up, but from a diagnostic perspective, A1C is going to be a 2 to 3 month measure average of your blood glucose levels, and anything less than 5.7% is normal blood glucose. Pre-diabetes, again, which says you're on the runway headed to diabetes, is where you have an A1C between 5.7 and 6.4. When you have an A1C greater than 6.4, that's when you're in full-blown diabetes. And you know, one of the things that I also like to stress too is in the research and the trials, some of the old trials, DCCT trials, they found that when you have an A1C greater than 7, you have an increase in likelihood of microvascular complications by 34%. So what that means is when you're above 7% in terms of your A1C, you have a higher likelihood of going into the problem of diabetes is the microvascular, macrovascular complications. What does that mean? So one of my passions is within the African-American community. Again, my grandmother called diabetes sugar, but that's also the same term that she called her grandchild. So sometimes we took the sting away from the disease because we called it sugar and we really didn't understand what the problem was. Well, the problem is when you're diabetic, you have excess sugar that's sitting in your bloodstream. That excess sugar, instead of being used to empower our cells, is sitting in the bloodstream, and then over time it oxidizes. Oxidation is equivalent to the rusting of metal, the browning of a fruit or vegetable. So, and what happens when my banana gets brown over time? My banana over time gets brown. A yellow banana is very hard and vibrant, but when it begins oxidation or this aging process, this accelerated aging, it gets weak. And if I squeeze a completely brown banana, it breaks easily. When I poke the rusted metal that is on a car that's been around a lot of salt that accelerates oxidation, it creates holes. And that's what happens in the blood vessels. And which ones does it happen first? It happens in the smallest blood vessels first, which are the kidneys and the eyes. That's why diabetes is the number one cause of blindness, number one cause of end-stage kidney disease. And then it happens in the larger blood vessels, the cardiovascular system, the nervous system, leading to amputations and leading to heart attacks and heart disease. One of the cardiologists I used to work with here in the city of Dallas, one of the top cardiologists, he always would say, Courtney, when a person gets diagnosed diabetes, he said, I can put it on a clock that they are 20 years from their first heart attack. Their first heart attack. And this is a very well-respected cardiologist, just because of the impact of diabetes on their cardiovascular system, certainly if it's untreated and undealt with. So those are the things that we have to think about when we think about those numbers. And that's why, you know, encouraging people to keep their A1C below 7 and also getting it down in a range of normalcy is huge. So type 1 diabetes is only 5 to 10% of the environment. And again, that occurs in childhood. It's typically called juvenile onset diabetes. Really is a result of autoimmune problems in the beta cells of the pancreas and beta cell destruction. And there are many different risk factors, but type 2 diabetes is the one that really affects our community. 90 to 95% of all diabetes cases. Most individuals struggle with weight, overweight or obese. Frequently it goes undiagnosed. And by the time they're diagnosed, they're typically in sometimes microvascular complications at that time. The risk increases with age, obesity, and lack of physical activity. And there's a strong genetic predisposition. So family history has a huge impact on the disease. Again, beta cell dysfunction in the pancreas can be a part of the problem and decrease insulin secretion and decrease insulin sensitivity of the muscles and increase insulin resistance. I'm not going to go into the details, but that's a part of it. And what we know is that microvascular, the smallest blood vessels, diabetic retinopathy, 35% of patients with type 2 diabetes have retinopathy, and the risk increases over time. 7% of patients have chronic kidney disease, have microalbuminuria at the time of diagnosis. 45% of them have neuropathy, diabetic neuropathy. So that happens as well. And then macrovascular, the larger blood vessel, coronary artery disease, heart failure, peripheral artery disease, and stroke. And if we think about the African-American community, very uniquely impacted by these conditions that are offshoots of type 2 diabetes. So when we think about some of the limitations of the impact, first we have to talk about, the impact of on our community specifically when you think about income, where 2018, the median weekly full-time pay, whites made $916, African Americans $694, Latin Americans $680. But then you look at uninsured Americans, 8.6% whites, 14.4% African Americans, 24.9%. So the ability to be able to have your medications covered has been a challenge. In addition to that, with a lower income, lowers the likelihood of you being able to actually treat yourself when you think about racial inequities affecting specifically access to these diabetic medications. And then when you get into this concept of pharmacoequity, where high quality medications being made available to African Americans, regardless of race, ethnicity, socioeconomic status, is something we have to think about more so, because it's directly related to policies and structures that really affect the African American population in a different way. Specifically, Black and Hispanics report highest rates of medication cost-related delays and lower access to high-quality medication. So when you think about that, we have to take in consideration conversations to enhance access to medications, reduce the cost of medications, and also improve the quality. Now, specifically, quality has to do with identifying prescribing inequities. Doctors, is there an under-prescribing of high-quality medications to African Americans? And studies have actually shown that to be the case in diabetes. There's one specific study, the Eberly study, showed that African Americans, Hispanics, and Asians were prescribed GLP-1s lower than Caucasians for diabetes, and that was significant over a 5-year period, and this was in the Optum care system. In addition, it was those who made less than $50,000 a year, and those who didn't have access to a endocrinologist, weren't able to go to an endocrinologist. So when you take that in consideration, it's pretty significant. And then lastly, we want to talk about policy options to improve access as well. So one of the solutions is for us to look at our policies and make sure that they address medication access as well. So I'm going to pause right now and kind of go to some of the questions in the chat and kind of address those. And Rhonda, I'll kind of yield to you at this time to kind of go through some of those.
Okay, great. Thank you, Courtney. So the first question we have in the Q&A box, and I think there's some in the chat box, but we'll go here first and then those in the chat box. So someone wants to know, what can they do to prevent diabetes because their mother had diabetes? And so I guess looking at hereditary factors, perhaps, based on that.
It's all about modifiable risk factors, right? What can you do to lessen your likelihood? Just because your mom had it doesn't mean you'll have it, but it does mean that you have a higher likelihood of being susceptible to it. So I would watch my weight. I would, want to watch my body mass index. Although sometimes I have a huge problem with some aspects of BMI because it doesn't take in consideration muscle concentration. Physical activity, stay active, and watch your diet. Try to eat as healthy as possible. Fresh fruits and vegetables, a lot of vegetables. Lean meats. Get enough sleep. Lower alcohol intake. You can do red wine is actually really good. So there's no problem with that per se. Watch your blood pressure, your cholesterol levels, just being aware of those things and doing everything that you can so that you can be as healthy as possible. And it's about the modifiable risk factors.
Great. And there's a question about what percentage of African Americans with type 2 diabetes go on to get type 1, but I don't know the answer to that question, but I would venture to say you're typically born with type 1, but you develop type 2, but you can clarify that.
Right. So what typically happens is over time, beta cell death does occur. So when you have type 2 diabetes, what we notice is that there is a slippery slope where over time, the beta cell does not produce insulin over time, and it's different for everybody, but there is beta cell burnout that does take place where you have a type 2 that then functions like a type 1. So that does happen. It does take place. So but it's variable. It's different for different individuals, but that can take place. So that's why you want to move towards, being as healthy as possible, physical exercise, and trying to reverse it through diet and exercise and making healthy choices and decisions.
Okay. And the next question is, someone says, I've watched a few YouTube videos from Dr. Joe TV. He makes videos regarding many aspects of diabetes. Have you heard of this individual? And if so, what do you think of the information he provides? Because he
I'm
seems
not
to provide a lot of
familiar.
recommend-
I'm not familiar with Joe TV. I'm not. I mean, I'm sure that there's a lot of people out there that are trying to talk about the disease. I would hope he's a clinician of some sort. But I would definitely, talk to your physician and or endocrinologist who are going to be the most knowledgeable about it. Clinical pharmacists who have a focus in diabetes are also very good as well, because a lot of us, we eat, sleep, and breathe diabetes as a part of what we do. But I would definitely try to find someone who's reputable. You can get information from the American Diabetes Association, find out when there are different workshops in your area where you can get more information about it.
Okay, great. And then someone wants to know, she says, I am living without a pancreas, and even though I take so many enzymes to help with oil leakage, the doctor keeps saying,
Yeah.
take more. How does that affect my diabetes? And also, why is my diabetes so difficult to control?
Yeah, I mean, that's a very unique situation. So the pancreas has a few cells. You have alpha cells, beta cells. You have the production of you have insulin release that's significant. You have glucagon release that's significant. And when you don't have a pancreas, all of that is certainly affected by that. And you do have to take other medications to supplement what's not being produced by your pancreas. So that's a significant challenge. So I would definitely find an endocrinologist who is really good at kind of helping you navigate through that situation, because again, there's so many different factors when you don't have a pancreas. But you can learn to live a healthy life, but you really have to have a physician to help walk you through that process. And that because that is a challenge.
Yeah. And then someone wants to know if they'll be able to get a copy of your PowerPoint slides. I don't know if you'll be able to share or if this is proprietary.
Rhonda, I'll talk to you about that, Rhonda. And if I can do that, I'll make it available to you to make it available to who wants it.
Great, thank you very much. And then Amber, I think we have a few questions in the chat box. Can you help us get those questions answered?
Yes, absolutely. The first one that we have gives a bit of context. There are a lot of great individuals who can do things like create a community garden, but with wages lower than ever, people are stressed and working many jobs and might not be able to grow their own food. How do you think institutions can support these efforts so it's not on individuals who are already overworked, underpaid, and have no sick leave?
Yeah, and you're right. And that's why sometimes we're going to have to look at outside the box. There are organizations like food banks, organizations that provide healthy foods for those in need. We're going to have to think outside the box, because you're right. We have some very unique challenges. And in light of that, it may take a food bank or for example, there are places here, community centers where they have fresh fruits and vegetables provided of no cost to the community. It's really going to take some outside the box innovative solutions to actually address that. I know the Hope Clinic in Houston does it, where they provide, the Diabetes Wellness Center here in Dallas does. I'm sure in California, there are organizations that provide fresh fruits and vegetables to the community, but it really will take you doing some research to figure out what some of those are, because you're right. We're in a very unique place post-pandemic. There were many people who lost their jobs. Our economy is still kind of heading back up towards functioning where people are able to be able to provide for their families. So we just have a lot of unique challenges right now.
Okay, next question, Amber.
Yes, and so these next two, I'm just going to kind of lump together. They're similar. Will someone that has been diagnosed with diabetes have to be on medication forever? And then also, if you have your A1C levels in the pre-diabetic range, is it true that once diagnosed with diabetes, you remain kind of classified as a person with diabetes forever?
No, that's not true. So certainly you can get your, I know plenty of people who've lowered, their A1C has gone back to normal levels. The thing is, if you get off the horse, if you will, you can easily creep back up to, where you're full-blown diabetic. The thing is, if you can get your A1C back below 5.6, around 5.6, 5.5, you're normal. You're normal, but it's something that you're going to have to work on and monitor and be aware of. So it's, yes, you don't have to be on medication for the rest of your life. There are plenty of people, it's a doctor's greatest joy sometimes to be able to tell patients, hey, you don't have to take diabetes medication. So it certainly can happen, but it takes a lot of work. It takes a lot of work, and it takes consistency. It takes consistency from a diet, from an exercise perspective. And so that's where you'll really see the benefits by doing those things. So no, it's not a death sentence. It's not forever, but it really will take discipline to turn around and maintain that.
Wonderful. Oh, sorry, Rhonda.
No,
What's your take on the soul food diet? Some of us believe that we should rid ourselves of it for these health reasons, while others said we should keep it because it's our culture. So just wondering, what's your take on cultural foods in relation to health?
Well, I mean, I don't think you have to eradicate soul food, but I think the way we've always prepared it, we have to reevaluate it. And we have to evaluate soul food from the standpoint of some of the soul food was the scraps that the master provided, or allowed slaves to have, which were not the best cuts or choices of meat, and not it wasn't the best. So we did everything that we could to season it so that it tasted good. So that meant extra salt, that meant extra seasonings that can actually be a part of the problem. So, so we have to really take that in consideration. How can we healthily eat, greens or vegetables, okra. Some of those vegetables are extremely healthy, but that doesn't mean we have to fry it. You don't have to fry your okra. You can boil your okra. I know some of y'all are like, ugh, I can't stand boiled okra. I love boiled okra. In Arkansas, that's what we had, so, or, instead of pork, you're more about chicken or lean beef or bison, leaner choice options, lower fat gravy, making things with low fat milk, just healthier options of how we prepare, and yet still have the soul food. And there are some organizations, and then vegan, for some, I know a lot of people who've gone to a vegan diet or a vegetarian diet where they cut out certain meats because they wanted to lower their cholesterol. They wanted to move towards being as healthy as possible, but it doesn't mean you have to sacrifice all flavor. I have a cousin who actually started a vegan where instead of meat, he does jackfruit. And he does jackfruit soul sandwiches and soul food options. He does a guacamole that he does, and he makes sure that it's healthily seasoned. He's turned his health around. He was borderline diabetic, completely healthy now. So there are things that we can do. We just have to, make the effort to bring about that change that we want.
Right. Amber, are there any more questions in the chat box?
There is one more. Should I ask the doctor to change my metformin to a new type 2 medication that helps with weight loss?
If weight loss is what you need, if you're not at your ideal body weight, if you're not at a place where you're seeing the A1C drop down, you might need to be put on a GLP-1. The recommendation, one of the pet peeves I have in the African American community, this is going to be in the next conversation where we talk about medications, is oftentimes in the African American community, we'll have individuals who are being treated in a way that's equivalent to going on an elephant hunt and using a small .22 pistol. So I'm going, instead of having a huge gun, and I'm sorry if you love elephants, this is just an example, is if I'm going on an elephant hunt, I need a big gun, right? because if I shoot him with a little pea shooting gun, a little bitty gun, I'm gonna make him mad and he's gonna trample me. And that's what diabetes is doing to a lot of people, is that, you know, you have an A1C that's double digit, but you're taking an inefficient medication. So an inefficient medication is just like inefficiently hunting. So the disease is getting bigger and it will trample you if you don't effectively get something to attack it the way it needs to be attacked. So absolutely, GLP-1s will be great with weight and with normalizing your blood sugars as well. So that's an option, and certainly talk to your doctor about that.
Great. So there's a few more questions in the chat. And one person says, I learned many parents put sugar in milk given to their babies. Have you found that to be a practice as common in African-American families and that are disproportionately impacted by diabetes?
Yeah, ooh, that made me cringe. Like, no, and I have 4 kids. No, you don't put sugar in their milk. I would hope not. You know, certainly talk to the pediatrician, but I don't think that that's a great, they don't need any excess sugar per se. And yeah, that's some of the stuff that sort of perpetuated some of the problems in our addiction to sugars, to excess sugar, which leads to a part of the problems of insulin resistance over time. So yeah, that's certainly unnecessary in my opinion. And certainly I think pediatricians and doctors would back that up as well.
Yeah, one of the sessions we're going to have is like no sugar baby, saying no to sugar.
Yeah.
And right. So we'll talk a little bit more about that and dive it a little bit deeper into why saying no to sugar is important, especially for the Black community. And then we have another question that says, as a pre-diabetic, besides testing, how can you, when you are at risk, otherwise, what are the symptoms that you are can see and recognize, I think is the question.
Well, the scary thing is you don't always have symptoms. Sometimes you do have polydipsia, polyphagia, where you're using the bathroom a lot at night. You have to get up and urinate during the night 2 and 3 times a night. You have air hunger, this what's called polyphagia, where you're excessively hungry and you're just kind of, it feels like you're never satisfied. This over obsession sometimes with sweets. You know, those are some of the things that you can identify, but unfortunately, you know, you don't always have symptoms. You know, it really, you know, there's so many undiagnosed diabetics. Those are some of the things that certainly you can look out for. But you know, I would watch out for excess urination and just an abnormal hunger, that type of thing. You can notice a body fatigue as well. Some of those are some of the symptoms that you could just be watching for. But, you know, getting screened is also really important.
Okay, and I think we have a couple more questions before we wrap up. One's in the Q&A box, one in the chat. But what are some of the best prescribed medications to help lower A1C level? I see many commercials advertised over-the-counter drugs that are supposed to help lower A1C. But what do you think about over-the-counter drugs and medications?
I stick to the AAC, the American Academy of Clinical Endocrinologists, the ACE organization, and the American Diabetes Association. They're always going to start you off on metformin. Insulin sensitizer is going to help you in terms of, and this will get to more into the treatment conversation when we talk about that next. So that'll be a part of one of our next sessions. So that's going to be, you know, probably number one, and then the GLP-1s, because they're going to help with a glucose sensitive release of insulin. So it's only going to work. And then also when you take in glucose, it's also going to affect glucagon release as well, which causes glycogen to break down in the liver, where you have, you know, where we have our own reserve system. Like, our bodies are amazing. We were designed to really fluctuate in a way that will be as healthy as possible. But we have actually messed that situation up, where we were very intelligently designed to be able to function. And so when you take in consideration GLP-1s, they work well, and then SGLT2s work well from the standpoint of helping to release through urinary excretion using the bathroom. Number one, excess sugar as well. So those work well for a subset of patients as well. So that'll be a part of our next, and so I have to, invite you guys to come back so that we can delve deeper into that, to the treatment options that are available.
Great. And then Amber, there's a question in the chat that we need to address.
Yes, I know we're over time, but they keep coming.
Okay.
Someone wants to know, I've just recently been diagnosed with high blood sugar. My A1C was 11.7. I do not have insurance and as a result cannot afford my meds. Can I reverse my diagnosis naturally? What can I do?
Okay, so there are options. Walmart has a partnership for Rely-On insulin. It's lower cost insulin. I would talk to your doctor about Rely-On being an option for an insulin. And when you have a double-digit A1C, most of the contribution is fastings, which means fasting responds better to insulin. So insulin would be really good to help get you down, at least, because you got to get that down. You got to get down, remember, below 7. You want to go below 7 because below 7 lessens your likelihood for microvascular complications, problems with your kidneys and your eyes. So I would talk to them, and Rely-On is a good program with Walmart to give you discounted insulin, sometimes even below $50 that you would have to pay. So I would go through that option, but there's ways in which to work around it if you understand where to go. And I would try to go through the Rely-On system at Walmart, because that's been set up to, and then also recognize that all the pharmaceutical companies have recently committed to lowering the cost of insulin. So you need to get that, because you got to get that A1C below 7 ASAP.
Thank you. And then a couple people wondering if you can define for us, what is GLP-1?
GLP-1 has to do with it is a GLP-1 is a lipoprotein that was found in the L cell of the small intestines. And what it does is, it's a type of drug. You have GLP-1 receptors in the brain, throughout your body. When you take a GLP-1, it does two things: glucose dependent release of insulin, suppression of glucagon, and then it slows gastric emptying. Okay, so the weight benefit is you slow gastric emptying, your food moves slower through your system, so you're not as hungry. It attaches to the GLP-1 receptors in the brain, and which are in the satiety center of the brain, which says that, hey, I'm satisfied. So you feel like you're full faster. So GLP-1 drugs are drugs such as Victoza, Ozempic, the drug, you have different drugs out there, Byetta. All of those different drugs are GLP-1 drugs that can be used. Toujeo, those things.
Any other questions in the chat, Amber?
Yes, one for Courtney and one for you. The last one, I have many of the symptoms. I have been told I'm pre. What screenings do I need?
Yeah, you need to go get a fasting blood sugar test ASAP. You need to go get one, and your doctor will have you come in the morning. You won't eat anything, and you do a blood test, and they'll be able to see where you are to figure out your fasting blood sugars. So that means you don't eat anything. You wake up in the morning, you go get a blood test, and then they'll be able to evaluate where you are. So you need to go get a fasting blood glucose test as soon as you can. And then they might do other tests to kind of really hone in on what's really going on as well.
Awesome, thank you. And then this last one is for you, Rhonda. Wondering if folks will be reminded to register for the events going forward, or are they already registered, I guess, from registering for this one?
No, you'll have to register for each of the 5 series or 4 more series that we have. So we will be sending out registration information for each of the different sessions to come. So hopefully that's a good indicator that you want to come back, and that this information that was shared today was really important and informative and valuable for all of us, or those of you who are dealing with this situation, to understand better about what the disease is and more effectively manage your disease.
And I said to JL earlier, it's actually Trulicity. That's what I meant. Trulicity, Ozempic, all of those are GLP-1 drugs, and Byetta, Victoza. So.
Okay. All right, great. So Courtney, thank you as always for bestowing your knowledge and helping us better understand whatever the topic is that we're talking about in our series with you and other things that we've done together. Just a few more things before we depart today. Again, I want to thank everybody for being here today. Again, this is the first of a 5-part series that we will do a deeper dive into diabetes, like let's dismantle diabetes so that we can all understand what it is, whether we're pre-diabetic or dealing with our diabetes and trying to more effectively manage it to prevent disease progression. And so we'll send a follow-up out to everyone who was on the Zoom today about what's to come, as well as the general public about that. But if there are any suggestions that you have or things that you feel is important for us to cover in the series going forward, we welcome your inputs. We want to make sure that we're meeting your needs and providing the kind of information that you've always been curious about or need to know, or may not have an opportunity to engage in a dialogue with your primary care doctor about diabetes and how to better manage that. So just a few reminders. You can follow us on social to keep track of what we're doing for the diabetes series, as well as many other series that we have scheduled over the next few months. So on social, it's easy to remember. It's at Your CBHN on Facebook, Twitter, as well as Instagram. We're on LinkedIn, it's California Black Health Network. Again, we have a series coming up in a couple of weeks. So if you go to our website and go to the events tab, you'll be able to see the complete schedule of what we have coming up soon. And so I want to say thank you again for taking time out of your day today to be with us. And please come back for the next session, and have a great afternoon and also weekend. Thank you very much.